Good evening, ladies and gentlemen. Thank you for inviting me to present lymphoma cases. In next 10 minutes, actually, in this, I am going to present Hodgkin lymphoma cases. Is really Hodgkin lymphoma still challenges in 2022? If it is there, what is their solution? So I will go through the diagnostic and therapeutic dilemma in 2022. So, what is the biggest challenge caring for patient with Hodgkin lymphoma in 2022? So, the 2022, you will find the most curable malignancy, but orphan disease for elderly and frail patients. Question is why? Answer is there because of advanced age, because of increased comorbidity, poor performance, and presence of B symptom, and elderly patients are less able to tolerate aggressive frontline therapy. This eventually leads to one third less survival as compared to the younger. Here you can say overall survival 90 to 60, and this drops from PFS is also 85 to 45%. So, in same context, I'm going to present 72-year female who had 2 month history of B symptom, typical B symptom, fatigue, and she noticed also there is one lymph node in the neck as well. Her comorbidity was osteoarthritis, hypertension, these symptoms increasing over the 3 months. And she's pallor, lymph node, and there is petechiae as well. So she has also cytopenia. That's why she was referred to us as a aplastic anemia to our oncology services. So she was admitted over there. Here you can say this is actually this red color is actually platelets. Its platelets is actually only 10,000, and even I checked platelets in citrate bottle is also 15,000, and the hemoglobin was 9 when she came. So she has a low WBC count as well. So it looks like something is there. So what we should do? So what is the most suitable thing which we make a diagnosis of this patient? So things is first we should check peripheral phlegm. So peripheral phlegm was checked and hemolytic workup was done. Hemolytic workup revealed normal and all nutrients was normal, ferritin, iron, beta, and folic acid normal. But phlegm revealed large platelets as typical seen in the ITP. So should we treat this patient as ITP? Answer is no, because she is 72-year lady. She has B symptom and she has also lump in the neck. We cannot ignore this one. Maybe this is secondary ITP. So we'll see which then other labs we should do for these patients. When you find elderly patient this scenario, first thing you will do bone marrow examination. Bone marrow did not reveal any evidence of any infiltration. Rather, it increased megakaryocytes were seen. It means it was compatible with the peripheral destruction, which is ITP. So what we should do next? Next, we should do, because there is lymph node, we should do some good imaging. She has high creatinine as well. So we did actually PET scan. In the PET scan, we found only 2 lymph nodes in the neck, but the activity is high, is about 10. Now what we should do, we call ENT surgeon. ENT surgeon say no, because it's 10 platelets, so I cannot touch the patient. So our thing is no tissue, no issue, but ITP is there. What we should do, if you go by NCCN guideline, so FNA is not possible. It's not adequate. The only thing is you can do excisional biopsy is the best thing is recommended, but core needle biopsy may be adequate if diagnostic. Sometimes you can do it. So in this patient, actually, we give by CT guided biopsy, they did actually core needle biopsy, and the lymph node from the left cervical, they found atypical lymphoid proliferation, and pathologist was not happy. They say, no, we need excisional biopsy. This is not adequate. Then what we should do next? So how I treat? I treat by NCCN, as I mentioned. As NCCN mentioned that FNA is not good. Sometimes you can do core biopsy, but if it's not answered, there do excisional biopsy. Now the question is how to do excisional biopsy. Again, multidisciplinary team, we call ENT. ENT said we need at least 30 to 40,000 platelets. The problem is this is the only 2 small lymph nodes. We don't want to give, steroid to push the platelets count up. So only thing is we did 1 dose of IVIG and plus backup platelets before and during and after surgery. And finally, we reached 30,000. They are digital. they help us to do excisional lymph node biopsy, and that came with the classical Hodgkin lymphoma. Now we have accurate diagnosis. The patient is Hodgkin lymphoma with high IPI score, and patient has the ITP. Now we have clear-cut diagnosis. So this is first is the accurate diagnosis we have. Now what we should do, the thing is Hodgkin lymphoma, the patient who have unfavorable stage 3 and 4 disease, the treatment is ABVD chemotherapy or ABR-VED chemotherapy. But remember, this was 2018, and I'm putting the guideline 2022. There was no concept of anything like, brontuximab plus something you can do sandwich, like brontuximab followed by AVD and followed by brontuximab, or you can do brontuximab plus DTIC. But in those days, 2018, there was only few phase 1 and phase 2 clinical trial was there. They suggest brontuximab single monotherapy can be given. So we tried actually in this patient. 4 cycle was given, and here you appreciate CR. You can see these were the lymph node before the BR, and this is brontuximab. After 4 cycle of the brontuximab, you can see it's all disappears. So she's in CR. So now what we should do? Should we do de-escalate? The answer is no, because she already took an actually adjusted dose of the brontuximab, and she also continued Revolade, and she also continued IVIG as well in the beginning. So she had completed 8 cycle, and after 8 cycles she's fine. And now over the 5 years she's following to us. Only she's taking ITP therapy. Otherwise she has in complete remission of Hodgkin lymphoma. So now what we learned in this patient, again, lymphoma ABC, first thing is accurate diagnosis. You have noticed, you will not miss the diagnosis. You notice we have done FNA, then TrueCut, then finally excisional biopsy, and even bone marrow biopsy, and finally we found the diagnosis. And before the beginning treatment, review the labs, as we found there is ATP, ITP, smear found large cells, and bone marrow also shows, it's like megakaryocytes there. And then important thing is consider potentially curative option with the least long-term toxicity, which we found here, as I told you, by serving the literature. We found brontuximab was good monotherapy, it works in his case. So now this is rule number 2. Then rule number 3 is never forget rule number 1, which is what? No tissue, no issue. Even we have gone 4 times biopsy, eventually we reach the diagnosis. So this is again one more slide for another patient, similar type of case, 72-year elderly lady with a multiple comorbidity, diabetes, hypertension, ischemic heart disease. Important thing, she has the chronic liver disease. She is cirrhotic patient, Hep C positive, and LFT is very deranged. And she was referred from some other hospital to us as a classical Hodgkin lymphoma stage 3. Now what to do in this patient? Again, now this is 2022. Now we have clear guideline. So what we did in this patient, we started actually brontuximab followed by AVD, and she is currently taking, these are the first PET scan which was done before brontuximab, and then another PET scan was done that revealed actually complete remission after getting AVD. So now the question raised in both cases, what we noticed, what is in your practice, what you choose in elderly frail patient, you choose only brontuximab or brontuximab plus DTIC or brontuximab sandwich therapy like brontuximab followed by AVD and followed by brontuximab, or you just give AVD or ABVD chemotherapy. So these are the questions we will discuss with the panel. Thank you very much.